our Inform CLL registry was done at multiple sites, and many smaller centers were included. A lot of those centers were community practices, and the uptake of CLL genomic testing was very low on this study. So what are the options, right? So this is widely available. So the genomic testing can include something called CLL FISH, which looks for the common, genetic abnormalities in CLL. It also includes looking for mutation in the P53 gene, and it also looks for IGHV mutation. Either they are mutated or unmutated. So these are the three main tests in terms of genomic testing. I think some centers use next-gen sequencing as well, but that is not as widely used. But the reason that these are important is that, some of this is actionable. The outcomes can be different depending on the treatments. There are some features which have high risk, high risk genetic features like deletion 17p or P53 mutation. And so those patients tend to have worse outcomes than patients with more favorable. And then there's also difference between IGHV mutated and unmutated. So even if it is not available in smaller centers in their local lab, these are things which can be easily sent out, and they can be performed. I will say that IGHV mutation analysis only needs to be done once and usually doesn't change in the course of the CLL. However, the FISH testing and the P53 mutation should be done at the time of progression as well, even if we have a baseline and the patient was observed or went through a line of therapy, because there is clonal evolution in CLL, and these are things which can accumulate over time. So at the baseline, at diagnosis, the incidence of high-risk mutations and high-risk genomic abnormalities can be low, but they can accumulate over time. So it's important to repeat it if patients are progressing or about to start a new line of therapy.